Hello, everyone. Welcome to our webinar today. I can see a number of you have already joined us. Uh, Invite your colleagues, keep joining. We have our speaker here already, so we will get started briefly. Let's just give 2 minutes so that we can set our house in order, and then we will just get started. My name is Dr. Bonke Arunga. I am your moderator today. I am a medical doctor. I serve in KMA as the convener for Social Responsibility and Welfare Committee. And I'm hoping that we're going to have a very wonderful time. So let's keep joining. In about 2 minutes from now, we'll get started. During the course of the presentation, if you have any questions, please put them in the chat box. So that I can aggregate them at the end. The last agenda would be to answer your questions in a Q&A session. Please put your questions here. I also recognize that we might be having non-medics in the webinar. So if you have questions, please don't feel shy or afraid to ask. This is a safe space, and this is one of the topics we want to provide as much information as we can. So if you have any questions, just feel free to uh, post them on the chat box. Just a little bit of housekeeping. Let me just confirm that my speaker can hear me. Dr. Ida, confirm that you can hear my voice and that you are in the meeting.
Good evening, Dr. Bonke. Yes, I can hear you.
All right. All right, I think we have enough quorum. In the interest of time, we have started 9 minutes after 7. Hopefully, we will finish in the next hour or so. Like I mentioned earlier, my name is Dr. Bonke Arunga. I will be your moderator today. I'm a medical doctor in Kenya. I am also in Kenya Medical Association as a convener for Social Welfare and Responsibility Committee. So today we are celebrating, or we are remembering, the World Contraception Day. We know that contraceptives save life, and especially in regions like ours where there is severely limited healthcare, and severely limited healthcare can lead to unwanted consequences for women going through pregnancy and childbirth. And so it is upon us to provide as much information as possible to the society so that we help prevent unintended pregnancies and also prevent the cascading consequences that might lead to that. That way, we can improve things like education and opportunities for women throughout their lives. So today, we are privileged to have one of our esteemed doctors in the country to help guide us through this topic. Our speaker today is Dr. Ida Lida Wanjiku. Dr. Ida is an obstetrician and gynecologist with a keen professional focus on adolescent sexual and reproductive health, urogynecology, global mental health, and health system management and policy. She's a 2025 One World Exchange Fellow with the International Federation of Gynecology and Obstetrics, what you know as FIGO. currently serving as the convener of the Physician Wellbeing Committee. She has previously held key roles, including immediate past convener of the Social Responsibility and Welfare Committee, and also a co-convener of the Young Doctors Network at the Kenya Medical Association. She has a set historical precedence as the inaugural residence lead coordinator of the Welfare Forum and Welfare Committee in the Department of Obstetrics and Gynecology at the University of Nairobi. A notable nominee for the prestigious 2022 Leadership Mashujaa Award by the Kenyan diaspora in Houston, Texas. Dr. Wanjiku is a sought-after mentor and youth empowerment advocate affiliated with the Kilidada, Areta Mentorship Network, the Emerging Leadership Leaders Foundation, and the M-Pesa Foundation Academy. In her community impact work, she's the founder of Dr. Lindsay Love Foundation, a transformative non-profit organization which ignites hope, embodies humanity, and radiates compassion, and the visionary leader of Regal Pageantry, an inspiring global women's empowerment forum celebrating identity and purpose. Beyond medicine, she's a fashion creative with impeccable eye for elegance, a refined vocalist, a music scholar, and professional Latin dancer, now channeling her creative expression in authorship as she awaits her debut literary publication. She's also a key contributor to the ongoing family planning policy formulation with the Division of Reproductive and Maternal Health, Ministry of Health Kenya, where she brings clinical insight and gender responsive perspectives into national reproductive health strategies around family planning. Dr. Wanjiku also sits in the technical working group on multiple micronutrient supplements implementation under the Division of Nutrition and Dietetics at the Ministry of Health, supporting efforts to improve prenatal nutrition outcomes through policy implementation, research, evidence, and system level collaboration. So we are privileged to have her speak to us. I'll also mention that this webinar is supported by Kenya Medical Association and Capricorn, which is the Kenya Pediatric Research Consortium, and KMA and Capricorn are working to implement SEBA, which is championing evidence-based advocacy for primary healthcare and reproductive, maternal, and neonatal child, adolescent health and nutrition. And as much as they are striving to provide information to medical doctors in Kenya, they're also doing their best to transmit this information to the general public so that we can improve our outcomes with primary healthcare. So I think we are in a better position to listen to what Dr. Ida is going to say. And you are also in the perfect forum to ask all questions you have about reproductive health and family planning. So without much further ado, I will ask Dr. Ida to start sharing her screen. And once that is sorted, she can take it away right away. Welcome, Dr.
Thank you so much, Dr. Bonke. That was such an elaborate introduction. Thank you so much. So I'll just like you to let me know that you're able to see my screen and if they are actually moving.
Yes,
So
I can see your screen. Yes, and the slides are moving, as you say.
All right. Okay. Thank you so much. So here we go. So happy World Contraception Day, everyone. It being the 26th of September, 2025, I would want to just make this to be a comprehensive awareness presentation. My name, as has been mentioned, is Dr. Wanjiko, and I am privileged to be your speaker for this evening. So Dr. Bonke rightfully said that this is a webinar that has been brought to us by Kenya Medical Association and Capricorn, and together they are working on championing evidence-based advocacy for primary healthcare, and RAMCA, which is reproductive, maternal, neonatal, child, adolescent health, and nutrition. And today being the World Contraceptive Day, the theme for this year is actually freedom to plan and power to choose. So this will be my outline of my topic this evening. So I'll give you a brief background on how did the world ever come up with World Contraception Day? What is the importance of this World Contraception Day? What are the theme and the priorities for this day? Then we'll have a snippet look at epidemiology from a global perspective, regional perspective, and then right here in Kenya. And then I will touch a bit about the ICPD 25 Nairobi Summit that was held in 2019 at KICC and what its relevance is to contraception. And then we'll delve into different contraceptive methods. And then we see how we can highlight contraception as a life-saving intervention and its overall impact. And then finally, we call all of us to action. And I'm hoping by the end of this webinar, I'll have convinced as many of you to be able to be champions, advocates for contraception, because yes, indeed, there's freedom to plan, and we want to empower you to be able to choose. So the background is this World Contraception Day was actually coordinated by the World Contraception Coalition. It is a coalition of several governments, health organizations, international bodies, other global partners who are working in consortium in the sexual and reproductive health. And it was first launched in 2007, whose primary aim at that time was to raise awareness about contraception, reduce unplanned pregnancies, and promote reproductive rights for all. So with time, this grew into a global movement with campaigns adapted locally, focusing especially on the youth, adolescents, teens, and underserved populations. And with this year's theme, it's a choice for all, freedom to plan, and power to choose. So this day is observed every 26th day of September. In fact, as we speak today, we had Kenya observing this day down at Makueni County. And this year we are aiming to improve awareness of contraception. We want to enable people to make informed choices about their sexual and reproductive health. And our emphasis is on access to accurate information, access to full range contraceptive options, and to empower all of us to make informed choices about their sexual and reproductive health. So why does this theme really matter to us? So number one is we want to highlight one of the rights that we have in this country and even in the world about bodily autonomy and your freedom to choose. And also we want to highlight gender equality. We want to be able to highlight all the barriers that we face and how we can be able to counter them. And then this is a call for a rights-based approach and also have youth-friendly services all over, both at the health facilities and even with our online based apps. And then our focus for this year's theme is to increase awareness of the contraceptive options and reproductive autonomy. And our target is all people of all ages, of all genders, and the emphasis is on informed choice and access for the same. So why do we need contraception? So of course, we want to prevent unintended pregnancies, reduce unsafe abortions, reduce maternal mortality and morbidity, and even to an extent reduce perinatal and neonatal morbidity and mortality. We also want to promote gender equality. We want to help in family planning and birth spacing. We want to empower women, the youth, and everybody to be able to promote gender equality. We want to support the achievement of sustainable development goals and enhance maternal and child health. So on the global perspective, we have more than 214 million women of reproductive age, that is 19 to 50 years in developing countries, who want to avoid pregnancy but are not using contraception. 214 million women. I want that figure to just stay with you as we go along so that you can see how much unmet need we still have to cover. And family planning could therefore prevent up to 1/3 of maternal deaths. And if we increase contraceptive use, then this will be linked to lower fertility rates and higher economic growth. So we have about 257 million women of reproductive age that have an unmet need for contraception, meaning they are ripe for it, they are of the right age for it, they would want to have it, but for some reason just are not able to access it. And then we have approximately 2.3 million neonatal deaths that occurred in 2023. And here, why I'm giving you these figures is just to show you that if we actually had more access to contraception, then we will bring down the percentage of maternal mortality and even neonatal death. So this is just a table to show you or from a global perspective what is happening. So I'd quickly want to highlight the need for family planning, where 1.1 billion women have a need for family planning. We have 874 million in the world using modern methods of family planning, and then 164 million that still have an unmet need for the same. Let's check the growth trends here. Since 2000, we now have modern use of contraceptions that have risen from 663 million to now 851 million women. So yes, we are improving, but we are not there yet. So come down to sub-Saharan Africa, where modern contraception would still remain lower than the global averages. And we still have a significant number of unmet needs with high fertility in most parts of sub-Saharan Africa. That's just a table showing the same. So for prevalence of contraception, there's an increase from 52% to 58%. And this increase happened between 2015 and 2022. So just an increase of 6%. And then if you check country level variation, Kenya, we're at 42% usage, Zambia 43.9%, Burundi 15%, and other countries 25 to 30%. Then down here in Kenya, so we are going to use the KDHS 2022 survey. Our unmet need for family planning stands at 14%. Our modern contraceptive prevalence rate has increased steadily from 2003, but our target still remains 64% by 2030. And for your information, 2030 is now no longer 15 years ago, it is 5 years from now. So I do not know, I'm hoping that we can all work together to be able to raise this MCPR by 64% in the next 5 years. So that's our epidemiology stats. So there's been increase, yes, a notable increase. 2017, 2018, we were at 37.2%. Then we rose to 44% in the year 2019 to 2022. Of course, we have disparity between urban non-migrant women versus women of the younger age groups of 46.6% versus 26.5%. And this is actually where we need to put most of our energy on, because right now our total population of Kenya, we have a lot of younger age groups, that is 15 to 24 years, that really need a lot of this contraception. And you can see as of now, we are at only 26.5%. So young women and adolescents have higher unmet needs, and rural areas will definitely show a lower modern contraceptive prevalence rate and a higher unmet need as compared to urban centers. And so our programs, as we are making programs wherever we are, we must be able to target adolescents and have youth-friendly services and major on marginalized and underserved counties. So let's now move to ICPD 25. This was the Nairobi Summit that was held in Nairobi in 2019. And at that time, they were marking 25 years since the Cairo conference that had been held in 1994. So if you're a Gen Z and you were born in 1994, you can imagine that was the first time the ICPD was being hosted in Cairo. So what happened in the ICPD is we have national governments, UN agencies, civil societies, we have people in the private sector coming together to be able to just accelerate progress towards universal access to sexual and reproductive health and rights. And in the 2019 summit, which now marked 25 years, they renewed their political commitment to sexual and reproductive health rights, family planning, gender equality, and financing. And so they really want to talk about they actually want to have a 0% of unmet need for family planning, and to ensure that there is access to modern contraceptive methods for all by 2030. Again, 5 years from now. Then they also want to strengthen commodity security and supply chains for contraceptives. They wanted to mobilize domestic and global financing for family planning and to prioritize adolescents and the young people with right-based contraceptive information and services. So they were hoping that that they would be able to together be able to reinforce the global agenda of reducing unintended pregnancies, unsafe abortions, and reduce the maternal and newborn deaths. So maybe now we change gears to the different types of contraceptive methods. But I feel like I'd want to take a breather and actually engage the audience. So if you are listening to me right about now and you can see my screen, I'd want you to engage me on the chat box by answering either true or false to these questions. So question 1, if you're ready, first of all, if you're ready on the chat box, just tell me, yes, I'm ready, ready, just write ready, 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 just so that I'm able to know that we are together. Bonke, you could help me. Dr. Bonke, you could help me know whether we have an active audience on the chat box.
All right. You can put an emoji, raise your hand, comment in the chat box.
Actually,
I can
comment in
see
the
that.
chat box writing ready, that you're ready. If you write that you're ready, then I will know that you're with me and we can be able
Yeah,
to.
I can see comments coming in. People raising their hands, their comments here.
All right. Okay. So, all right. So question 1, you cannot get pregnant if you have sex during your periods. Do you think this is a true statement or a false statement? If you agree with it, type on the chat box true. If you don't agree with it, then write on the chat box false. So Bonke, you can help me with what's happening on the chat box.
There is true, true.
All right. Okay. Do you have
True
any more?
responses.
All right. Any more responses? So you cannot get pregnant if you have sex during your period. Most people are answering true. Is that so, Bonke?
Yes, true.
All right. Okay. So just let's note that down. All right. Number 2 is birth control pills cause permanent infertility. So if you agree with it, write true. Yes, it will cause. Or if you don't agree, then write false. Birth control
False,
pills.
false, very false.
All right. All
Yeah.
right. Okay, great. All right, great. Okay. Do you have any more responses before we move on to the third question?
Several people are saying false. I'm not
Okay.
seeing any true response.
All
So,
right.
mhm.
Okay, thank you, thank you, thank you so much. All right, let's move to the third one. So the third one is emergency contraception causes miscarriages. So emergency contraception in this case means that you had engaged in sexual activity prior to you using a contraceptive method. Then you now went to get an emergency contraception. And so you feel that this emergency contraception leads to causation of miscarriages. So if you agree with it, say true. If you don't, then say false.
I
Bonke?
can see several people saying false. False. There's no true response.
All right.
It's false.
All right. So we can move on to the next one. So next myth that we want to bust together is you don't need contraception if you're breastfeeding. You don't need contraception if you're breastfeeding. Is it true or false? You don't need contraception if you're breastfeeding.
People are saying false.
Okay.
Yeah.
All right. So next, condoms are 100% effective at preventing pregnancy. Condoms are 100% effective at preventing pregnancy. Mm-hmm.
There's someone who says no contraceptive is 100% effective.
So are they saying
Someone
true or
says
false?
false. False.
Mm-hmm.
That's not true.
All right. Okay, let's do a bit more. Okay. Okay, just a minute. I think we just hung. Just a minute. All right. Are we back? I hope we're
Yes,
back.
we are back. Continue.
All right. So I'm not going to ask that one. 2 condoms provide double protection. Okay, if you would, okay, let's answer that one. That one is more of just an icebreaker. So 2 condoms provides double protection. Wearing of 2 condoms provides double protection. And that would either be a man wearing 2 penile condoms or the man wearing a male condom and the woman wearing the female condom. That is still 2 condoms. So if you feel that is true, then you say true. If not, then write false. Yeah. So Bonke, you're my eyes on this one. What are the answers?
False.
Okay.
All right, false.
All right. And then also, as we go on, our ICT personnel, Sharon, if you could enable the chat box so that people are able to use it. I can see a few comments saying that they feel that their chat box has been disabled. If you could work on that as we continue, that would be great. All right, then long-acting reversible contraceptives like intrauterine devices are only for women who've had children. So long-acting reversible contraceptives like intrauterine devices are only for women who've had children. What do we think? Okay.
I only see false responses.
All right. Is a chat enabled now?
Chat is not working. I think people are using the Q&A.
The Q&A. Okay, fine. So we
Station, yeah.
continue.
We're working on the chat.
All right. Okay, so a few more questions. Maybe let's do natural methods like withdrawal method or the fertility awareness method are just as effective as the modern methods. So natural methods like withdrawal method or the fertility awareness method or what we call the calendar method, the one that you're counting your days, are just as effective as modern methods. What do we think?
I can see false.
All right.
There is one true.
Oh, okay, good. Okay.
There's
All
one
right.
true.
All right. Okay. And then men have no role to play in family planning. Men have no role to play in family planning. I'd have loved to see male responses, particularly on this one. I can see
Very
someone.
false. Very false.
All right. Okay. All right. Then the last one is hormonal contraceptives and tubal ligation lower libido in women, or they lower a woman's sex drive. So tubal ligation, that is a bilateral tubal ligation, causes a low libido in women, and also hormonal contraceptives cause a lower libido in women. What do we think of the chat?
False.
Mm-hmm.
False.
Mm-hmm.
False. Yeah.
Okay. All right, so then maybe we go back to, so we will discuss them just in a bit. Just hold on to those answers. We will discuss them as we go along. So from the myths, or from the questions that we have had from the myths, you have already known that we have the natural methods and we have the modern methods. So the modern methods are, we could have barrier methods, those are the diaphragms, the condoms, the cervical caps. We could also have hormonal methods like the pills, injectables, implants, patches, hormonal intrauterine devices. And then we have now the permanent methods, which is for women, tubal ligation, and for men, vasectomy. And then I just added down there that we also have emergency contraception in the form of using pills or the intrauterine device. So we'll quickly just go through all the methods with their advantages and disadvantages. I tried to make it as simple as possible because I was anticipating would have an audience that are not healthcare professionals, and so we wanted to make sure that everybody could understand what we are talking about. So barrier methods, we have the male condom. It is worn on the penile appendage. Advantages, it's easily available almost in every shop, every pharmacy, anywhere you go, you can easily get the male condom. It protects against STIs. It is non-hormonal, but the disadvantage is it may break out or it might slip out. It reduces sexual sensitivity, and it definitely requires partner cooperation because there are partners who would say they don't want it being used on them. So those are the disadvantages for the male condom. Female condom, this one is inserted into the vaginal canal before intercourse. That means the woman should have worn this condom like an hour or so before the actual act. So the advantage to this, it's female control. So for women who want to feel that they are in control of the contraceptive method, that would be a good choice for them if they wanted to go the barrier method way. It also protects against STIs, and it is inserted before intercourse. The disadvantage is it's uncomfortable to wear, it's so cumbersome. In fact, I'd want to just ask, has any of us on this call actually seen a female condom in the last 5 years? So between 2020 and 2025, we have seen a female condom. If you've seen it, just say yes, 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 yes. If you've never seen it, just say no, no, I don't know how it looks like. No, no. So how are we doing?
People have not seen it.
People have not seen it.
There's
That's how.
someone who's seen it.
Okay, okay. There's
Quite
one
a
person.
number have seen it actually.
Okay, okay, great. Okay. And then it's also a bit costly as compared to the male condom. It's not as available. Like if you just want, well, go to your local pharmacist or chemist, it's not as available as the male condom. So those are some of the disadvantages. And then it is very user dependent. The lady needs to have already been taught how to do it, how to insert it, how to twist it and put it upright and be confident enough to, to use it. All right, then the cervical cap or the diaphragm, it's also inserted into the vagina and it goes to cover the cervix. The advantage is it is reusable. It is also female controlled and it is non-hormonal. The disadvantage would be that it needs fitting, and once it gets displaced outside of the cervix, then it becomes ineffective and it has no STI protection because this is just covering the cervix, so it has no STI protection. Then moving on to the hormonal methods, we have the oral contraceptive pills. You use it 1 tablet orally once a day. The advantage is it's highly effective if it's used correctly. It also is used to regulate your menstrual cycle, and research shows that it reduces ovarian and endometrial cancer risk. The disadvantage of these oral contraceptive pills is it must be taken daily. You cannot skip a day. And it has no STI protection, a very high risk for thromboembolic events, DVT, pulmonary embolism, and the likes. And there's a contraindication for women who are smokers. You've ever had a thromboembolic event before, you currently are a patient who has been treated for ischemic heart disease, you are a chronic hypertensive patient, you have been treated or are being treated for breast cancer, so then you would not be a candidate to use the COCs. Then we have other pills, the progestin only. So difference between the combined oral contraceptive and the progestin only is the COCs have both the estrogen and progesterone. Progestin only pills only have progesterone hormone only. The use is you take it every day and you have to take it at the same time each day. Advantage is it is suitable for patients who are breastfeeding, and it has fewer contraindications than those of the combined oral contraceptives. Disadvantage is it is time sensitive, and if you have even up to a 3-hour delay from the time that you are supposed to be taking it, then the efficacy reduces. Another disadvantage, because it is progesterone only, it may cause some women to have irregular bleeding. Then we move to the injectable. You inject it, depending on what you're using, you can inject it either every 2 months or every 3 months. Advantage is it is longer acting. Once you get that shot, you only go back to for the next shot 3 months or 2 months later. It's very discreet. There is no evidence that you are on any contraceptive, unlike the pill, where you literally have to carry your bottle or whatever, where you're putting your pills. So it's very discreet. The injectable is also safe in pregnancy because it is progesterone only, and it is also highly effective in preventing pregnancies. Disadvantage is this person, the client needs to go to a trained provider to give them the injectable. Because it is progesterone only, it may also cause irregular bleeding in some patients, and definitely it has no STI protection. So we move to the implant. The implant is what you actually insert. It's a rod that is inserted under your skin of the inner upper arm, and it can be one that lasts 3 years or the Jadel that lasts 5 years. It is definitely highly effective. It's a longer acting method because you see it gives you 3-year coverage or 5-year coverage. It is safe in breastfeeding because it is progesterone only. Disadvantage is could cause irregular bleeding and also does not have any STI protection. Then we move to the hormonal intrauterine device, commonly in the market is known as Mirena. It is inserted into the uterine cavity, lasts up to 10 years. Advantage is it's long acting. It actually benefits women who have heavy menses, and it is very effective. The disadvantage is the client would require to go to a trained provider to have it inserted properly. We make sure that it is placed well, it is not misplaced. Nowadays, we even advocate for using analgesia because putting in an IUD is actually not the most comfortable of procedures, and definitely has no STI protection. Then the transdermal patch. It's a patch that you apply on the skin and you replace it weekly for 3 weeks, and then you have a 1 week patch-free week to allow for your menses to go through. Advantage is you use it weekly, unlike the pill that you use it daily. Is very effective if used correctly, but if it just detaches from your skin, that is it. It is not, you're just going to get pregnant. Another disadvantage is for some women, it has been shown to cause skin irritation. Of course, it does not have any STI protection, and it is less effective for women with a high BMI. So we move on to non-hormonal methods. We have now the intrauterine device that has copper instead of the hormonal impregnated one. It's also inserted into the uterine cavity. Advantages are it's highly effective, does not have any hormones, and it also is used as an emergency contraception together with the pill as well. Disadvantages is it may actually cause the opposite. It may actually cause heavier, longer periods with abdominal cramping. So that is, what some patients have actually talked about. And then we also talk about the lactation amenorrhea method. This is where women who are exclusively breastfeeding have amenorrhea, and so they're actually, we know that it is effective up to 98% if that criteria is met. So the period should not have returned since her date of delivery, and she's exclusively breastfeeding every 2 to 3 hours, they're really, following that criteria. The disadvantages, of course, is only effective up to a maximum of 6 months. But for most women, we have seen it goes not beyond 4 months, because after the 3rd month, the menses resume. And then, of course, it requires exclusive breastfeeding, which is not feasible for most of our working women. After the 3rd month, after 3 months are over, the 4th month, she needs to go back to work. And so that exclusive breastfeeding, as it were, may be interfered with. And then lastly is the fertility awareness method, or what we call the tracking method, or what other people call calendar method. Advantages: there's no cost, there are no hormonal use, and it's also acceptable in some religious and cultural groups. Disadvantage: it requires a lot of discipline. It requires the client to have a very regular menstrual cycle. And definitely it does not have any STI protection. On to the more permanent methods. There's a female tubal ligation. It's a surgical procedure that blocks the fallopian tubes. Advantage: it's permanent, very effective. Disadvantage: it's actually irreversible. I've actually seen a couple of clients coming back requesting for a tuboplasty after a tubal ligation, and you go in and so there's already adhesion. There's not really nothing you can do about it. And of course, it does not have any STI protection. Then there's vasectomy for the men. So a surgical procedure that blocks the vas difference. It's permanent, it is simpler, it's highly effective, but the disadvantage is it's irreversible. Once you've gone that way, chances of reversing a vasectomy are, I think I was told is less than 3%, and no STI protection as well. So let's just quickly go through our myths. I wanted to put that there so that we can discuss them together. The first one, there are people who say that it is true you cannot get pregnant if you have sex during your period. And drum rolls, the answer is actually false. You can get pregnant during your period, especially if you have a short cycle. So if those ladies who are at 21-day cycle or thereabout, and remember also we have sperm that can live in the female genital tract up to 5 days after ejaculation happened. So if you're thinking you're safe because you're on your period, well, not so much. All right, so next one was birth control pills cause permanent infertility. I think I remember most answers were false, and yes, it is false. Birth control pills don't cause permanent fertility. In fact, if anything, there's a very high return to fertility once you stop using the birth control pills. The other one was emergency contraception causes miscarriages. I think most of our answers were false, if I remember. And that you are right, it is false. It is false. Emergency contraception prevents ovulation, and it will not harm an existing pregnancy. If the pregnancy is there, it's there. So it will not be able to induce an abortion. However, emergency contraception actually increases the risk for ectopic pregnancies. So there the trick was, it was not miscarriages, but ectopic pregnancies. All right, then the next one was you don't need contraception if you're breastfeeding. There are some people who say true. So this one, it is only true if the lady is following the criteria. The criteria being that they are exclusively breastfeeding every 2 to 3 hours. They have not yet, they still have amenorrheic. They've not yet resumed their period since the delivery. So this one, the answer is actually false. So if you're not following that criteria, then you may just get pregnant. And then condoms are 100% effective at preventing pregnancy. I remember there's somebody who wrote that there's actually no effective, there's no effective method when using contraception, and you are right. In fact, the only known 100% effective way of preventing pregnancy is abstinence. All right, then using 2 condoms provide double protection. I think everyone just said false, 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 and yes, it is false. Then long-acting reversible contraceptives like intrauterine devices are only for women who've had children. I think here we had more falses than true, and I agree with that. Yes, it is false. So it is effective for women of all ages, whether they've had children or not. All are welcome to use. Definitely after you've had a conversation with your provider, healthcare provider. They will see what would be best for you to use. Then contraceptives cause cancer, definitely false. Natural methods like withdrawal or the calendar method are just as effective as modern methods. I remember there were a few true statements there, and this is actually false. It's not as effective because, as we've said, this lady has to have a very, very whatever cycle, regular cycle. You know, if it's every 28 days, it's like calendar work every 28 days. If it's 21 days, you know, it's like calendar work. And if it keeps on, today is 21, then the next day it's 25. I mean, next month is 25 days later. Then another month is 28 days later. Then might not be the best for you. Maybe think about other modern methods to supplement. Yeah. The point about men having no role to play in family planning, I love that everybody unanimously said men are very key partners in family planning. Male involvement improves the outcomes. It will even support shared responsibility and even encourages informed decision making. So that was good. I think everybody said false to that one. And then the last one about libido, I can't remember what we said. I think there were, I don't know whether it was true or false, but tubal ligation does not cause low libido because tubal ligation is an anatomical issue versus libido, it's a neurophysiological issue. So the two do not really meet anywhere. And then the issue about hormonal contraceptives always lower a woman's sex drive. So here, there are some hormonal contraceptives that may lower a woman's sex drive depending on other factors. You know, it's multifactorial. We can't just blame it 100% on the hormonal contraceptives, but yes, there are studies that have been made, that have been conducted, that have seen other people actually getting a lower sex drive. And on the contrast, there are also some women that have reported to have had an improved sex life because they now have a reduced anxiety about pregnancy, you know, and whatever other factors that were causing the low libido have already been addressed. So yeah, here it can either go left or right. Thank you so much for engaging me on the myths and contraceptions. That was amazing. I enjoyed your answers. So let's now change gears to contraception and the youth. So definitely young people are facing barriers to accessing contraceptions. And you see, there are so many myths out there. We've only tried to bust 10 or 12. And you can imagine how many more other myths are out there that are maybe hindering them from usage, including even our parents feeling, or rather the youth's parents feeling like if I talk to my child about contraception, then that means I am actually encouraging them into sexual activity. Yeah, so we also need to have youth-friendly health services everywhere in every health facility to improve access to contraception and also empower young people to promote safer choices for them. So what would be some of the challenges in contraceptive use? So one, religious beliefs, cultural beliefs, like I think I was talking to people from counties like Mandera, I think it was Mandera, Garissa, and I forget that, and Marsabit, yes. And they were saying that they feel like this contraception is actually coming to completely tell their women not to deliver. And you see now that needs a lot of teaching to be able to tell them that, you know what, we are not coming to stop fertility completely. We just want to, you know, to make it, to have birth spacing. We want this mother to be able to heal from the whole pregnancy journey and the fourth trimester, be able to breastfeed properly this baby for at least 1 to 2 years. So it's there needs to be a lot of teaching around why contraceptive is good for everybody. Other challenges, of course, include supply chain issues, gender inequality, and lack of enough male involvement. Of course, on the supply side, we could have stockouts. Like I think there was a time when male condoms in this country, I think the last 3 months or so, were actually were stocked out, and those that were on the shelves had actually expired. I think if you remember such a story, I think the company was Durex. I may be wrong, but but there was something to that end. And then, of course, we may not have enough trained staff on family planning at every facility to be able to provide the care that is needed. Then on the point of policy and financing, we may not have enough domestic funding and also have weak integration because we actually need family planning to be one of the primary healthcare anchors. Yeah, so we need to really integrate family planning to be as how you go to a facility and the first thing they do, is BP, then they check your vitals, then the next thing should be family planning. So I'm hoping that one day we will get there. So some of the strategies to help us increase our uptake would be get youth-friendly services to cater for the adolescents and the youth, get comprehensive sexuality education everywhere, remove all financial barriers, get insurance coverage. Like by now, SHA should be able to be covering all types of contraception and even on board all the private insurance companies to cover for contraception of whatever type it is that the client decides to use. And that would really help us in, increasing coverage for contraception. So last thing maybe I'd want to do before we wrap up is just to have a snippet on how contraception can be a life-saving intervention. So number one is it enables healthy birth spacing. It improves the outcomes of both the mother and the child. Two, it will reduce the high-risk pregnancies, especially for clients that are too young or too old or having too many pregnancies too soon. And then it would empower women and couples with reproductive choices and have their autonomy strengthened. And then it would definitely prevent, unintended pregnancies and lowering the risk for unsafe abortions and even maternal harm. So as we have said before, contraceptions lower the maternal mortality by preventing unsafe abortions. It also decreases the risk for hemorrhage, the risk for eclampsia, the risk for obstructed labor in high-risk pregnancies, especially for them that we have said either too young, too old, too many, and too soon. Also prevents complications of closely spaced pregnancies that strain maternal health, and it definitely would contribute to achieving the Sustainable Development Goal 3.1 target of reducing the global maternal mortality ratio. We have always been aiming for less than 70 per 100,000 live births. Currently, Kenya, as of this year, we are at 355 per 100,000 live births. So we still have some mileage to go. And of course, it also reduces exposure to risk of pregnancy in women with comorbidities, especially cardiac disease, HIV, anemia, and so on and so forth. Also, it would prevent preterm births associated with short interpregnancy intervals. What is recommended is actually to have an interpregnancy interval of 24 months, that is 2 years, between one pregnancy to another. It would also reduce the incidence of low birth weight and related complications. It would enhance newborn survival by allowing families and even health systems to allocate more care and resources to the child. And it would improve exclusive breastfeeding and child survival through adequate birth spacing. So if we quantified all that, how would that look like? It would look like family planning being estimated to avert a sustainable fraction of maternal deaths. It would be able to help us meet the unmet need for contraception, which would thereby, by a large share, be able to reduce the number of unintended pregnancies, reduce the number of unsafe abortions, and be able to integrate contraception with maternal and newborn services, which would have so many benefits, including financial benefit, economic impact, social impact, like you name it. So I just use this to highlight what is currently happening. As you were told earlier when Dr. Bonke was making the introduction, I'm privileged to serve in the policy formulation process of this country under family planning. And this is the direction that we are currently taking. So we want all women of reproductive age to have access to their choice of contraception, devoid of judgment, bias, or discrimination. We want to ensure that there's universal access to safe, high quality, effective, and diverse contraceptive options. We want to guarantee a resilient and responsive national supply chain to family planning, health products, and technologies. We would want to have a sufficient national budget allocation for procurement, warehousing, and distribution of health products and technologies of family planning. We would want to foster a multi-sectoral partnership to harmonize efforts in accelerating our commitments to family planning. We also want to enhance knowledge and skills for human resource. That is, we want at the very least, to have one trained healthcare professional at every facility that has been appraised of the newest methods and techniques, and that skill and knowledge is actually being revised every 2 years. So if you go to any facility, whether it's a level 1, level 6, there has to be at least one trained person for family planning. So that's really what we are pushing towards. Of course, when we say one at least, the number could be endless. We just chose one because there are some level 1 dispensaries and so forth that would only have 1 or 2 healthcare providers. So maybe if one is out on leave, then we have one. So we're just really hoping that we can have the level where at least we have a trained healthcare professional with their up-to-date skills of counseling, and then giving the appropriate contraceptive method, and provide quality family family planning services. And then we would want to prohibit all forms of reproductive coercion. And we would want to see family planning services being made as part of an essential and emergency response in humanitarian settings. And especially when we have natural disasters, emergency setups, like when we had COVID in 2019, I'm sure the last thing we all thought about at that time was family planning. And, to this day, we still call the babies that were born around that time COVID babies. So if you can imagine a Kenya where family planning services are still essential services, like, like any other, as an emergency response in all humanitarian settings, then that would be great, including even when there's, the internally displaced persons, when there's any natural disaster of any kind, floods, famine, whatever it is. If you can always maintain family planning services, then that means we'd even reduce the risk for unintended pregnancies and all this that happen during disasters. That would really, really be a great Kenya to live in. So as I come to a close, I'd want to call all of us to be able to take our positions in ensuring that contraception is a well-known idea, that we accept it, that we are using it, that we are not demonizing it, that we are encouraging we are encouraging the access to all the wide range of contraceptives, depending on the client, because it has to be client based. It's not a one size fits all. Then would really want a world, or rather a Kenya, where we promote open dialogue and reduce stigma. And especially for the youth, we want them to be informed. We have, I think so far we have 2 or 3 chatbots applications that even talk in Sheng, and you can ask it a question and it gives you an answer in Sheng, and especially talks to you about contraception. So I think that would be encouraged for the youth that have smartphones. And for the youths that don't have access to smartphones, then let's inform them to just use contraception, because we already know that they are having sex. So we would better just allow them to take charge of their reproductive health. So as I conclude, this day, which is the World Contraception Day, is a reminder of the importance of access to contraception, informed choices. And so we want every individual to be empowered through education, through awareness, through the service that they're receiving. And that would contribute to a healthier family, stronger community, sustainable development, and even economical impact. So I'm inviting all of us to be part of the change. Remember that we want to ensure that everyone has a choice to plan their family. This is a choice for all, freedom to plan and power to choose. And together, we can ensure that every individual has the knowledge and the freedom to make informed choices about their reproductive health. Thank you very much for listening to me. Over back to you, Dr. Bonke.
Thank you so much, Daktari. This is the session for Q&A. So yesterday, prior to this session, Daktari, I sent out some polls for questions, and I got quite a number of responses. But now I'll summarize them to three because you have done an extensive presentation on almost every aspect. I think there are other concepts that you mentioned, but we may need some clarification. So I'll just ask you three questions. Maybe you can clarify on them, and then we will conclude from there. The first one you had mentioned about it, about contraceptives causing libido. The question was not if they cause libido, is how can someone manage low libido caused by contraceptive? So this was an anonymous sender. I think they all wanted to find out if there's anything you can do uh, if you are suspecting that contraception has caused low libido. I'll ask the other questions so that you answer them at once. Then there are a number of users who wanted to know what is happening in the contraceptive world for the males. Other than vasectomy, are there any non-surgical alternatives for the males other than condoms, let's say? Or if there are any medications that are available at this point. And then the third question you have mentioned, and I saw it also in the chat box. Someone was wanting to know your comment on anesthesia use during IUD insertion. I also saw a similar thing on the chat box, and you had also mentioned it earlier in your presentation. So maybe you can comment on those three, and then I'll keep checking the chat box if there's any other question.
All right, thank you so much, Dr. Bonke, and thank you for the question. Maybe I'll start with the last one about the use of analgesia during IUD insertion. Actually, yes, if your healthcare provider as of September 2025 is not using analgesia or some form of anesthesia while inserting the IUD, then perhaps you should think twice about it. We have seen studies where, and even patient complaining, so many clients have been complaining over in the past that it's ridiculously painful to have the IUD inserted without any form of anesthesia. So we have, everywhere we are recommending that let's please have some form of anesthesia. You can either do a saddle block, or you can do a cervical block, or you can, whatever the doctor or the trained provider is using, just to make sure that it is a painless procedure. Remember, at the point of insertion, the cervix is actually closed. And so we are putting in the IUD inserter through a closed cervix, and you have to, like grab the anterior lip of the cervix to be able to bring it closer to you before you insert, and that would be really, really, really painful. So so for as long as the client says there's pain is very subjective. You cannot tell a patient who is telling you they're feeling pain that it is not painful. They are the ones feeling the pain. So just if they're feeling pain, just make sure that you prepare yourself adequately before you do the insertion, and then make sure that the patient or the client is as comfortable as possible. And it's actually being accepted everywhere to use analgesia and anesthesia, whatever form of anesthesia for IUD insertion. And then there was a question that you asked about what else is happening in the where about male contraception, excluding condoms and vasectomy. So the field is actually advancing with both hormonal and non-hormonal approaches, but they're still under development. Nothing is in the market as yet. We have a couple of clinical trials in their preclinical stages, and for that end, because I don't think they'd want to produce anything in the market if it has not been tested. But of course, there are major approaches under study. The first one would be the hormonal method that would be aiming to suppress sperm production. The other one would be a non-hormonal method that would be targeting either sperm formation or sperm transport or the sperm function. But all these are under study. And of course, they're also thinking of a device-based method or an occlusive method at the vast difference. Same concept as a vasectomy, only that it is reversible. Yeah. But all these are all under study. Nothing is completely out of the market yet, save for the barrier methods for the male condom and vasectomy, which is a surgical permanent procedure. So as more trials are being conducted, then with time we should be able to know, the way forward. I may have forgotten the third question, Dr. Bonke. Maybe if you could remind me the third question, please.
All right, I'll remind you the third question, and then there are also two questions from the chat box. So the third question is what to do if you're suspecting that your low libido has been caused by contraceptives, or what to do if contraception is causing low libido. And then there is someone on the chat box asking why BTL failure, or why can a BTL fail? And then there is someone asking if emergency pills are taken accidentally by a 3-week pregnant, what would be the dangers?
All right, thank you.
Over to you.
Thank you so much, Dr. Bonke. So, so the question about what would be the practical thing to do if a patient who is on contraception is experiencing low libido. So number one, as I had tried to mention earlier, is low libido is actually multifactorial. It could be a number of causes, in addition to maybe the contraception of use that the client is on. So it could be a psychological factor. It could be a relational factor, like they're just having so much conflict. There's partner dynamics in the works. There's a lack of intimacy like it was before. It could be that the client is also under other types of medications, like maybe some types of antihypertensives, some types of psychiatric medication like antipsychotics or SSRIs. It could also be that the patient is having some psychological factors like maybe depression, anxiety, stress. So if we remove, or rather we rule out all those other factors, and we remain with the contraception as the cause, then what we can do is withdraw that contraception use, observe whether ask the client if they and their partner would be willing to go and hop onto a barrier method. In the meantime, observe the patient, see whether there's anything that is associated. Is there dryness? Is there pain during sexual activity? Did the mood change, resolve? If we get to know all that, then we are certain that that contraceptive method was a problem. So once we jump onto like a barrier method for like a few months, and then we can review with the client again and see what would be a better option for them. And then remember, we just don't enter into a facility and are just given whatever option. We have to take a really detailed history of the client to know even their BMI, whether they have any chronic conditions like thyroid problems, if they are antihypertensive, if they've ever had a clot, what we call DVT. There's so much history that goes down to it. And as always, we tailor all these contraceptive methods to the client, because it's not one size fitting all. So definitely one of the interventions that I've said, one is try an alternative contraception. So maybe stop the contraception she was on, move her to a barrier method, observe whether whether the libido has come back or however it is. And then if we really, really are certain that, yes, that was a problem, then we are ready to switch to a completely different method. And then if maybe the patient or the client was in a hormonal contraceptive method, you can consider moving her to a non-hormonal option. Yeah, that would also be something that would be good. And then definitely sex therapy, a lot of counseling, because the act of sex is so much psychological, psychosocial than it is just a anatomical act. And then there's a question that you said about why would a BTL fail? Thank you for that question. So a BTL would fail maybe because of the skill, because it's a skill dependent, because the anatomy of the uterus is such that the fallopian tube looks very, very similar to the ligament. So if you, by very, very unfortunate means, tie the ligament instead of the tube, then it would really fail. Another thing would be that when they were doing, depending on the procedural method they used to perform the BTL, because we have various surgical types of doing it, depending on how they did it, if they were not sure that they actually saw two separate tubes, separated, the tube could actually cause, there could be adhesions and the tube just comes back together. So it's more of the surgical, technique per se, as it were, either by failure of actually closing the tube and by accident, tying the ligament, or it could be that the choice that they, the choice of the surgical procedure that they chose to go with, would allow the tube to, to just come together and whatever. But the chances should be low if it's done. If it's done properly, then we shouldn't really have a BTL failure. All right, there's a question here on if emergency pills are taken accidentally by a 3-week pregnant, what could be the danger? Nothing really. If she's already 3 weeks pregnant, an emergency pill is loaded with progesterone, you'd actually be supporting the pregnancy even more. So nothing much to worry about, but maybe ask the client to go to a healthcare facility, get an ultrasound done and see how the pregnancy is going on. And then a question here about consent for family planning in case where a teenager comes for the services. Right, this is a very great question. Thank you for asking that question. So about consent, it would be good to know, is this an emancipated minor or it's just, what we mean by emancipated minor is, has she ever been pregnant before, or has she used another contraceptive before and then now she's coming for a refill, or is this the first time she's coming to do so? Then 2, there's a point about, parental involvement and the risk of the parent, literally just, getting so upset about the teenager going for family planning services. So first of all, as always, take a good history, with no bias, no judgment, no nothing. Get to know, how did they know about this? How did they come to the point where they know that they would want a contraceptive option? What is available for them? What is their relationship with their family? Is there anybody who's also harassing them sexually? There's so many questions that you would ask around it, but at the whole point is they need to make an informed choice after you have done all that. And if you feel that if the parent being involved would actually, the parent being involved is an advocate for the family planning, then you can request a second session with the parent and then we go together. So it's a very sensitive and a crucial area, because you see, when we say informed consent, and then there's a point of the teenagers here in Kenya, if you're below 18, then that means you're not old enough to give consent, But again, remember, adolescents are considered capable of consent only if they understand and appreciate the implications of that decision. And remember, for teenagers and adolescents, what they really want is confidentiality. They want to feel like their privacy is respected. They want to feel that, they want to know that there's a very low risk of harm, and definitely we don't want any form of coercion. So it would be very good for you to take that opportunity as a healthcare worker to know, how come this teenager at 14 is coming for contraception? Is there rape going on in the family? Is there incest? Is there molestation of any kind? Is there peer pressure? As yes, they have the right to access contraceptive services without discrimination, but it also be a really amazing time to get to know what would be the surrounding factors around that. And then without bias or judgment, then be able to move forward. Yeah, that's how I could answer that question. Bonke, I'm not sure whether we have any more questions on the chat.
No more questions on the chat. I can also see that time is so much spent. Thank you so much, Dr. Aida, for simplifying what could otherwise be a very complicated topic and helping us celebrate this World Contraception Day. We are also thankful for Capricorn and KMA for sponsoring such a webinar, and we are hoping that they will sponsor another one again so that we keep these conversations going. I want also to thank the listeners who have joined us. I am glad that we have both medics and non-medics here, and Dr. You've done well in simplifying the information while also maintaining the truthfulness, validity, and the integrity of medical information. So we appreciate you so much, and we hope that when you are called upon again to talk to us about matters family planning, obstetrics, gynecology, and family health, then you can take up the mantle and present yourself again. Otherwise, thank you so much. For anyone who is interested in the session, it's a recorded session. You can find it on the YouTube channel for Kenya Medical Association, hopefully by next week. Otherwise, thank you so much for attending, and you can all leave at your pleasure. Have a good night and a happy weekend.
All right. Thank you and good night.